And this kind of continues the theme of what we've been hearing today. Ghana is one of those countries like Jordan where there's intense multinational military engagement. And he has been the surgery point of contact, boots on ground, and has engaged with many different groups from Navy, US, Army, JTS, and very similar situation as Dr. Maddox has described, where groups are coming, overlapping on groups. And so one of the main things that he has been working on over the last several years with the Center for Global Health Engagement is getting a UN level 2 certification and hospital ready to deploy to South Sudan. He has deployed multiple times throughout Africa in support of that and is a general orthopedic and trauma surgeon. And I will turn it over to Dr. Adzigbli.
So as a way of introduction, I would say that military medicine has been an integral part of the Ghana Armed Forces and armed forces in general since militaries were created. Now, the focus has generally been towards prevention and then treatment of infectious diseases. Added to that, we've had to be treating wounded casualties in battle. So the surgery basically focuses on treatment of wounded casualties from battle. So from there, it resulted in the setting up of combat support medical reception stations, also known as MRSs, and regimental aid posts with some surgical capabilities. In peacetime, these facilities were converted to bigger hospitals and with diverse specialties, including orthopedics, pediatrics, general surgery, and public health. And it serves both military personnel, their families, their dependents, and even the civilian populace. I have been with the military hospital for the past 12 years, and I've been a member of the Ghana Armed Forces for the past 12 years. I joined as a specialist orthopedic surgeon, and I've been practicing orthopedics for all these years at the military hospital. So the aim of my presentation will be to give you an overview of how we practice surgery in the Ghana Armed Forces at the 37 Military Hospital. The scope will include, as shown on the screen, various surgical divisions and how the organization works in peacetime and during operations. And I will talk a little bit about IPREP, which is a flagship program that I've been involved in. Now, the surgical division is headed by Colonel, and all the currently OIC, as we call him, or officer in charge of the division, is Colonel Richard Mensah, who is a general surgeon. And all the departments are also headed by Colonel, except for orthopedics and trauma, which is headed by me in acting capacity, and Lieutenant Colonel, waiting to be promoted to Colonel. So we have the plastics reconstructive unit, we have the neurosurgical unit, we have the cardiothoracic unit, we have a urology unit, we have the maxillofacial unit, and then the allied surgical unit, including the ear, nose, and throat, and then the ophthalmology unit. And you know you cannot do surgery without anesthesia, so we also have anesthesia covered. We recently had one of our officers train in vascular surgery, so that's one of the units we are trying to have established. And all this will not be possible without, of course, a general surgical unit. So we are all under general surgery. So what's the role in peacetimes? It's similar to what pertains in most civilian hospitals. The specialists in various departments run their own clinics. My clinic days are Mondays, and we have one theater day, which for me is on Tuesdays. We have one emergency day, and you have weekend duties that you run. Now, all these things means that you need to have second line managers, third line managers. So that's where our residents come in. The trauma and surgical emergency is the first point of call for all emergencies. And when they come in, the resident surgeons in training provide triaging, we do the initial resuscitation, and separate the patient into their various specialties where definitive care will be planned. So most of us specialists will take turns to provide cover for our resident doctors. Now we are organized as specialists into various teams for daily ward rounds, which occurs for some units one day in the week, and for we have 1 day in the week for major academic and teaching rounds. I do 3 ward rounds in a week. I do teaching rounds twice a week. The surgical department provides teaching for, we have medical students, we have our house officers, we have student nurses, we have rotations, and then we have our residents that we provide teaching for. And in collaboration with other divisions like public health, we do preventive care through routine screening, especially for breast cancer, prostate cancer, cervical cancer. At 37 Military Hospital, where I work, and which is the main military hospital in Ghana, remains at the forefront for management of disasters, rain, flood, fire, road traffic accidents, etc. And we also provide medical cover for major military exercises nationwide. Now, in operations, our operations range from internal security through peace support operations, and then when there is actual outbreak of war, which we pray we don't have. So the military hospital deploys forward operating bases, which is the MRSs and RAPs, and which are hospitals with very limited surgical capabilities. So these are usually manned by senior medical officers, and they have medical officers with them. And the senior medical officers are trained to be able to handle emergencies at that level, stabilize the patient, resuscitate the patient, and then transfer the patient to the nearest facility. And in such situations, surgical operations are limited to mainly trauma. Okay, and then we deal with life-threatening infections, surgical infections as well. And the focus is mainly on damage control. We stabilize the patient and transport the patient to higher levels of care where complex surgical procedures are available. So what are some of the common surgeries we do? This includes laparotomy, we do thoracotomies, thoracostomies, fixation of fractures, debridement of wounds, and sometimes we have to do amputations, which may be either guillotine in type or complete amputations. And we also provide medical support for long-range patrols. Where there are casualties, then we have to do medical evacuation, and sometimes we have to do passivacs as well, where there are casualties who end up losing their lives. And thanks to APREP, we now have the capacity to be able to provide tactical field care and first aid lessons to our troops prior to their being deployed on missions. Now, trauma remains the major cause of morbidity, requiring surgical intervention in our various operational theaters. So the surgeon must plan ahead on the various modes of management, especially where there are mass casualty incidents. So most of the time we rely a lot on communications that get to us from the force medical officers and the various medical officers at the forefront. So when the information gets to us, we plan, set up the appropriate teams, and then make sure that they are ready to receive the casualties. And these are some of the things that we do during our simulation exercises under APREP. So knowledge of triaging is fundamental so that you can maximize efficiency and the resources that are available, especially to us in a resource-limited environment. So the surgeon needs to be very well acquainted with ATLS principles, and this comes to play in initial resuscitation. I happen to be one of the trainers when it comes to ATLS in our environment. So these are things that we do. And we also do training in airway management, both basic and advanced. Now, various battlefield injuries can occur. You see gunshots, explosions, burns, motor vehicle accidents. So the patients and casualties are brought to you in various stages and with various degrees of injuries. And sometimes too, in fact, most times we see patients with polytrauma. So then it means that you have various systems being involved. So we need to do a multi-system approach for their management. So in the non-operational areas, trauma is mainly MVA related, so VCRT, road traffic accident related. Now, the craze in our country is motorbikes. So we have the motorbikes taking majority of our roads, and 70% of the casualties that we have involve those using motorbikes. We get various types of injuries ranging from extremity injuries, which may be mild, to very severe, complicated crash tissues requiring amputation. As we speak, I have 2 patients who are waiting to have amputation because of crushed limbs. So other injuries we encounter are blunt, penetrating injuries of the abdomen, various degrees of head injuries, thoracic injuries, chest injuries, and then sometimes we get cases resulting from assaults. Due to the increase in motorcycle accidents, we are now getting quite a significant number of spine injuries. And this is getting worrisome for us since we lack neurosurgical support. Currently, we have only one neurosurgeon on ground. So that is one major challenge that we have. Neurological and vascular injuries are encountered, but they are less common in our various facilities. So patients with abdominal injury, somebody with a scalp laceration are brought into the ER, and we have to manage them. So in our hospital, trauma accounts for the highest cause of morbidity, and most mortalities are due to severe traumatic brain injuries and high cervical spine injuries. Some too are brought in dead, and these are usually from hemorrhage, which are usually catastrophic hemorrhage. So, and then because of a poor transport system in our environment, getting access to injured casualties, putting them on board an ambulance and transporting them to the nearest health facility can take quite significant amount of time. And all these delays result in poor outcomes for the patient. When patients come in and they die eventually, sometimes it's from either thromboembolic events or from sepsis. Now I'll talk a little bit about APREP. So we had this collaboration with the United States Department in 2015, and under the CHGE collaboration, the Ghana Armed Forces managed to be a beneficial partner to this program. The Ghana Armed Forces has been deploying troops to various fields of operation since the 1960s. We have been involved in peace support operations across Africa and in Asia and in various parts of the continent. There have been many interactions and training activities between the 37 military hospital and medical personnel from the United States military. So we've had training on air evacuations, we've had training on ATLS, we've had training on trauma nurse care. So there have been various trainings that has helped us and has enabled us to have the capacity and the logistics to be able to deploy rapidly in management of various disasters, both home and abroad. So during the COVID-19 pandemic, thanks to APREP, we were able to mount a mobile clinic to help manage and treat some of our patients who needed such care. It was not easy, but we were able to pull through. So APREP provided us with 2 fully equipped mobile deployable hospitals. One of the setup is for training purposes, so that's what was set up and we use for our various simulation exercises. It has an outpatient department, has an emergency, it has a theater suite, has an ICU, and it has 2 wards capable of holding patients of up to 6 each. We have a laboratory and a dental unit. Like I mentioned, the training sessions we had training sessions on trauma response. We had medical modulation simulation exercise on ultrasound images. We had CASIVAC training in all that in collaboration with the United States personnel who came down to support us. We also had a vendor training prior to be able to set up our facility. So these are some of our staff dressed up during one of the simulation exercises for a client who was brought to the ER who needed with a traumatic amputation, and we had to salvage the limb. Yes, we did this simulation during part of the process of vetting to be able to deploy a level 2 facility in South Sudan, where thanks to APREP, Ghana now has a medical unit established in South Sudan, and we are performing quite excellently. The United Nations are happy with us, the locals are happy with us, and we are getting very good reviews. And all this would not have been possible if we had not had the support of the United States to be able to have such a facility. So, like I mentioned, we deployed the level 2 hospital during the COVID-19 pandemic, and we still continue to have training of our military personnel in mass casualty situations at the 37 military hospital, thanks to the logistics provided to us under APREP. And in South Sudan, it's a very, very notable and laudable experience that we have there. Now, what are our challenges? Most of the challenges we have are faced during operations in the field, and these include limited tools for imaging. So currently, the troops that have deployed, they have a mobile mobile X-ray unit, and that is not even adequate for them to do imaging of patients. And where there are complex injuries, even be able to do ultrasound and all that is quite challenging. And our laboratory that we had also had limitations, so we are not able to do some investigations, including blood cultures, PCR toxicologies. And then access to blood and blood products, which is a major limitation for our troops there, because we get quite a significant number of casualties from blast injuries, gunshots, and they need to transfuse the patients, and there's limitation of blood product. And antimicrobial agents, yes, so in our environment, the first line of medications that we use include penicillins and then cephalosporins, but these are in limited supply in the environment. And then we also have limitations in respect of equipment for major surgeries and monitoring of our patients. So I'll conclude, I hope I've not exceeded my time, by saying that military surgery forms a critical part of military medicine, and the military surgeon is responsible for restoring the health of the fighting force, especially during war times. In peace times, we provide care to the civilian population, provide care to our families, we provide care to even foreign dignitaries that come to our countries. It's involved to a large extent triaging, resuscitation, and then damage control surgery. ATLS still remains the cornerstone of initial management, and the peculiar challenges faced have been enumerated in the previous slide. Thank you very much for your attention.